Hello student, hello everybody. Today we are going to start the topic of pulp and periapical diseases. No, pulp. First we will see what is pulp and where it is present. Pulp occupies the central portion of the tooth. It is the formative organ of the tooth. It builds the primary dentine during tooth development, the secondary dentine after tooth eruption, and then a reparative dentine in response to the stimulus. So these are the main functions of the pulp, which are very vital for protecting our tooth for the life of the tooth structure. Now, what is the composition of pulp? If we talk about pulp organ, basically consists of two parts. Number one, coronal, which is present inside the crown portion of the tooth, and then a radicular portion, which is present inside the roots or root canals of the tooth. It varies, there can be single roots, there can be multiple roots. No, pulpitis. What is pulpitis? If we define it as, it is inflammation of the pulp, which is known as pulpitis. And the principal symptom of this inflammation, which normally patient complain, is in the form of a pain. It can be of any sort depending upon how much pulp is affected. It can be mild pain, it can be severe pain, it can be continuous pain, it can be intermittent, comes and goes type of pain. If we look into the picture, we can see healthy tooth and then infected tooth, in which we call it as pulpitis. Healthy tooth, the pulp is present, it is living, nerves, blood vessels are there on the left side if we see. And on the right side picture, which is of pulpitis, inflammation of pulp, when the tooth is broken down or carious, the pulp is exposed and it becomes infected. So we call it as infected pulp or pulpitis. No, pulp or pulpitis basically responses in the form of various signs and symptoms, which normally we can say alert the patient, the affected person, to take it serious and to visit to a dentist. It can be like pain when patient tries to bite down. It can be pain when patient tries to chew something. It can be in the form of a facial pain, sometimes whole of the side of the patient, of which side the tooth is present, that it patient complains a type of pain. And sometimes patient is unable even to focus which tooth, upper, lower, or which anterior or posterior tooth is giving pain. And then there is sensitivity. Whenever patient tries to take any hot or cold stuff, food or beverages or drinks, it appears in the form of a pain. And then discoloration of the tooth, when that pulpitis remains there for longer time, it basically changes the color of the tooth. Now, how we can diagnose the pulpitis? There can be clinical findings, which normally patient shows or the dentist examines. It can see the changes, it can see the broken tooth, any swelling, anything like that. And then radiographs, in which we actually find the extent of that pulpitis or pulp infection. Either it is limited to the crown or it is spreaded into the roots or below or beyond the roots into the alveolar socket or into the tissues. And then third one is the pulp vitality test. This is again very important. Sometimes we check either the pulp is living or it has become dead, because if the pulpitis is present for longer time, what we call as chronic pulpitis, the tooth normally loses its vitality, it becomes non-vital or dead. No, the diagnostic test can be simple percussion. We simply tap the tooth with some instrument and patient responses either in the form of a pain, mild or severe. Then in the form of radiographs, we can find out exactly how much tooth is damaged, how much pulp is affected, and which area has been affected by the pulpitis. And then palpation, we simply palpate the tooth, gently palpate, and we see the response of the patient. And then thermal, we apply something hot, like very common thing is we use hot GP point, we touch it to the tooth surface and see if the patient shows any sensitivity or response. And then electrical pulp testing, we have a special device, EPT, electric pulp tester. We check the trigger, the level of at what level the sensitivity is, the tooth responses to the electric test. No, what is the etiology of the pulpitis? If we talk about the first main is the bacteria, the most common thing, in which there can be periodontal pockets, then there can be toxins associated with the caries, then malformed teeth, the cracks in the crown. All these things basically promote the action of bacteria on the tooth, resulting in pulpitis or damage of the tooth, affection of the tooth. And then some traumatic things like crown fracture due to some reason, some accident, some fall down, ball hit, something like that, or root fracture sometimes during some treatment, or similarly some trauma. Then tooth avulsion due to some accidents again. Then bruxism, which is a habitual things, habits, they can cause bruxism, and which can in severe cases can lead towards the pulpitis. And then abrasion, some abrasives, use of abrasives, chemicals which can expose the pulp, resulting in pulpitis. Then some iatrogenic effects, unknown causes like heat generation due to some other uses. For example, dentist is doing some filling of the tooth, and that heat which is produced during hand paste, that can affect the pulp and cause pulpitis. Similarly, depth of the preparation, the cavity is prepared, dehydration of the tubules, pulp exposure, filling materials, all these things sometimes can lead towards the pulpitis. Now, how we classify the pulpitis based on clinical features? It can be reversible, it can be irreversible. Now, reversible pulpitis, pulp is capable of recovery after the stimulants are removed. For example, sometimes only minor pinhole size pulp is exposed, and if we timely cap it, or sometimes if some stimulus is there, some hard things are causing irritating the pulp, if we remove those, pulp becomes can be recovered. Then irritated pulp tissue responsive to earliest and slightest of inflammatory stimuli. The pain is sharp and intense in this case. It responds to thermal changes. It remains there for 5 to 10 minutes and doesn't last longer than 20 minutes. So it is for shorter period of times, giving good indications that we can save the pulp. And then position of body doesn't affect the pain. It is very important again feature, especially in the reversible pulpitis. We can see sometimes because in case of other cases, severe pulpitis or irreversible cases, if the patient lies down, the pain becomes very severe. Again, it starts, whereas in reversible cases, it doesn't. Posture of the body of the patient doesn't initiate any signs and symptoms. The treatment is protection of the pulp from the thermal exposure and some sedative dressings. We protect the affected portion and the what we call as a reparative dentine is formed, and then that saves the. In case of irreversible pulpitis, what we see, pulp doesn't recover after removal of stimuli. It can be acute or chronic type of inflammatory changes. It is of variable intensity, pain especially for sharp or to dull, but in most cases it is usually dull pain, less intense pain compared to reversible pulpitis, but here we can see it lasts longer for longer period of time. It is less in intensity, slow pain, dull pain, but it remains there for longer time, 30 minutes, 40 minutes, 1 hour, affected by the patient's positioning. Again, very important. Whenever patient lies down, it pains starts, which is very painful condition for the patient. Difficult to localize and lasts longer than 20 minutes. So treatment is the only option. Either we have to treat the pulp, we have to do root canal treatment, or remove the tooth, extraction of the tooth. No, the comparison in reversible and irreversible, here the pain is sharp, in irreversible sharp to dull pain, less than 20 minutes, more than 20 minutes, not affected by body position, affected, easily localized and difficult to localize. No, this is a picture for pulpitis. Left side there is pulpitis, in the middle we can see we go for root canal treatment, and then we fill the root and do the treatment filling, or if we tooth is more damaged, we can put some crown on it. So here is the acute pulpitis. Is a two types: focal acute pulpitis involving one horn of the coronal pulp, total acute pulpitis involving the whole of the pulp. Etiology can be includes the sudden overheating of the pulp resulting in blood vessel ruptures, and these conditions are usually seen during the crown preparation, especially in the absence of a coolant. If means the water coming from the handpiece is very important, that basically cools down the handpiece, doesn't let the teeth heat up and convert into a pulpitis case. Histologically, we see it is very much similar to the abscess. It is also known as pulp abscess, composed of acute inflammatory cells, necrotic tissue, fibrin, extravasated RBCs. There can be sometimes granulation tissue consisting of fibroblasts and plasma cells. Then toxins released by the pathogens and enzymes. Then there can be, after necrosis, we can see exudate travels in the deeper tissue from the periapical foramina into the periapical area, affecting the periodontium. From the periodontium, it can even further spread into the surrounding bones and then medullary bones. In case of chronic, there is low-grade pain, low-grade irritation. Mostly we see older patients, older teeth with old restorations or slowly progressive caries. Then there can be dentinal tubule sclerosis. These teeth, they have reparative or secondary dentine, which forms a barrier against the pathogens, but there is still a way for the bacteria to enter into the pulp, and slowly it causes the pulpitis. Similarly, histologically, we see loose fibrocollagenous connective tissues having lymphocytes, chronic inflammatory cells, lymphocytes, plasma cells, and we also call it as pulpal fibrosis. Then we can further see pulp stones, which are spherical stone formations, and then dystrophic calcification, linear calcification as a result of chronic pulpitis. They can be present anywhere inside the pulp, in the coronal pulp, as well as into the root pulp portions. Then prolonged chronic pulpitis may lead to pulp necrosis, whole death of the pulp, then periapical lesions, which can be associated with, if it is composed of fibrous nodule with a mild infiltrate of lymphocytes and plasma cells, we call it as granuloma. Means this chronic pulpitis, if it remains there for a longer time, it converts into a periapical granuloma, which basically consists of fibrous tissue along with lymphocytes and plasma cells. Then chronic hyperplastic pulpitis, what we call is a pulp polyp as well. What is it? It is a productive, that is growing inflammation of the dental pulp, in which the development of granulation tissue is seen in response to a persistent, low-grade, continuous irritation and bacterial invasion. All things are present and for a longer time, and then they convert into a hyperplasia of that inflamed pulp. It is mostly confined to the molars of young children with large pulp chambers and non-sclerotic dentinal tubules, and they occur as a result of rampant caries in small children. In young teeth, the apical foramina, they are basically wide open, leading to excessive blood supply, which again we can say helps this inflammatory tissue to further proliferate. The regenerative capacity of the tissue along with the blood supply, it leads to hyperplastic pulpitis. The pulpal tissue will proliferate out of the open carious lesion. The exposed tissue that becomes what we call it fibrotic over a period of time, and then there can be asymptomatic and of normal colored tissue in there. It may be red if it is ulcerated or infected, and also called as pulp polyp. Now we come towards diseases of periapical tissue. If we don't treat this pulpitis, it can further affect the tooth area, the socket, the surrounding tissue, which are in the deeper tissue, which we call as periapical diseases, like periapical periodontitis, spread of infection to the apical periodontal ligament area, ligament region. In the picture, if we can see, it can damage the ligaments, it can result into the mobility of the teeth and then loss of the tooth structure. Clinically, it can be acute or chronic. There can be mild pain with a very mild chewing pain with percussion, and on periapical palpation, tooth appears slightly elevated. It appears like it is mobile due to inflammation and edema in the periapical region in the deeper tissue. Like it is floating, it looks like tooth is not fixed, it is just like a floating tooth. If we see in the radiograph, if we see the arrow, there will be radiolucency in the periapical area, loss of lamina dura in the periapical region, then very widening of the periodontal spaces because of accumulation of pus-like tissue in that areas. So the only option is the possible treatment is endodontic. If the dentist can do endodontic treatment to remove the infection, the infected pulp, and then periapical infection. If it is not done good, the only other option would be the extraction of the affected tooth. Then, if we don't treat this periapical periodontitis, it further converts into a further anomaly, what we call as periapical granuloma. It is a localized mass of granulation tissue which forms around the affected apex of the wherever infection has drained into the deeper tissue, that become fibrous granulation tissue formation, and it converts into a granuloma. It can be asymptomatic sometimes, mild pain present, then present pain while chewing something, and similar tooth is elevated or feels like a floating from the socket. In the radiograph, we can see a sphere radiolucency, which is basically granuloma abscess formation in the periapical region, in the affected region. The cause we can clearly see in the radiograph was the caries of the crown portion, radiolucent area attached to the tooth apex, well circumscribed, demarcated from the surrounding bone. The only option in this case would be the removal of the tooth, extraction of the affected tooth. And if very good endodontic treatment, root canal can be done, we still have to go for episectomy, removal of the affected root. Then periapical abscess, which clinically appears in the oral cavity, a small swelling on the affected side, acute or chronic suppurative process of periapical region of the tooth. Here we can see the caries, the discoloration of the tooth, regional lymphadenitis, fever of the patient sometimes, chronic form which presents with no features. There can be opening sinus tract from where the pus is discharging into the oral cavity. Here in the radiograph, similar features, radiolucency around the affected portion of the tooth or affected periapical portion. What we have to do, we have to drainage of the pus, we have to facilitate removal of the pus. Then obviously the other treatment would be the extraction of the affected tooth. Endodontic if someone can do it, otherwise mostly we have to remove the tooth. And periapical cyst, we have already gone through. If granuloma persists there, present there, we don't remove it, that periapical granuloma will convert into a periapical cyst. Similar radiographic features, radiolucency around the affected periapical foramina, well circumscribed, unilocular radiolucency, and the treatment option is the removal of the tooth and then removal of the cyst, enucleation or marsupialization of the cyst. Then dento-alveolar cyst, alveolar abscess from the due to dental, for example, affected pulpitis, infection enters into the alveolar socket, so combination is called dento-alveolar abscess. Infection beyond the alveolar bone and involves the neighboring soft tissues as localized form, a bigger soft swelling on the affected side. In the picture we can see on the left side of the patient a bigger swelling. It is acute onset. Pain is continuous. It is described as extreme, growing or throbbing pain, localized intraoral and extraoral swelling we see in those patients. There can be trismus in severe cases. Patient would be unable to open or close the mouth. Then there can be lymphadenitis, and then there can be pyrexia. fever conditions of the patients. This is a sequelae of pulpitis. All over we have gone through in a picture form the areas of the enamel, the dentin, and then start of the pulpitis, which then grows into different things like acute pulpitis or chronic pulpitis, then periapical periodontitis, a periapical abscess, periapical granuloma, and then into the either in the form of a cyst, periapical cyst or radicular cyst, or in the form of cellulitis or dentoalveolar abscess. This is again the same thing, infection, then interaction of the host like the tooth, tissue, plus bacteria or viruses, and then environment, hygiene conditions, all these things lead towards the disease. No, the odontogenic infections, acute, they can be chronic, abscess or cellulitis, and then fistulous tract sinus or osteomyelitis in case of chronic. No, what is cellulitis? Very important, very you can say sometimes common conditions if we don't treat the pulpitis cases. It is a diffuse inflammation of soft tissues which is not circumscribed or confined to one area, but in contrary to the abscess, it tends to spread through tissue spaces and along facial planes. In a simple words, we can say spread of infection into the soft tissues is called cellulitis. This is picture of cellulitis, diffuse infection of the connective tissue with severe inflammation, redness, heat, pallor of the dermal or subcutaneous layers of the skin, whatever area is affected on the face or any other part of the body. It can be caused by normal skin flora or by some exogenous bacteria, and often occurs where the skin has previously been broken or ulceration presence. Etiology can be bacteria, either in case of oral cavity, streptococci or staphylococci, a minor injury to the affected side skin like a cut, scratch, infection in a person with diabetes or weak immune systems, impaired circulations where blood supply is affected, periapical infections extending into the soft tissues in case of dentistry, oral cavity. It may reach up to the palate, causing swelling of the orbit and nose. There can be certain risk factors like diabetes, old age, depressed immunity, and patients on some immunodepressive drugs. Clinically, if we see, there will be painful swelling of the involved soft tissue, involved affected area. There will be inflammation, change of color, purplish skin, elevated temperature, fever condition. In case of maxilla, there can be cortical plate which is perforated along with breaking of the buccinator muscles causing swelling of the upper face. This is basically in case of severe infection. Then there can be trismus in case of severe infection. Patient cannot open or close the mouth. Regional lymphadenitis, infections become localized, and abscess formation. If we see histologically, there will be exudate of lymphocytes, leukocytes with serous fluid causing separation of the muscles and connective tissues. And the treatment options will be the antibiotics and the removal of the stimulus of the infection, whatever is the cause. And sometimes we have to go for surgery as well. If we compare the cellulitis and abscess, we can see cellulitis, it can be acute, abscess is mostly chronic. Then there can be pain, size, location, your localization. There can be response to palpation. Cellulitis is sometimes toughy to indurated area, whereas abscess is fluctuate very soft. Presence of pus in case of cellulitis, sometimes pus is very less, whereas in abscess it is totally filled up by the pus. It is very, that is why it is soft. Bacteria then involved can be aerobic, and in abscess case there can be both aerobic as well as anaerobic mixed. No, if we talk about the Ludwig's angina, it is a very serious, potentially life-threatening cellulitis, severe form of cellulitis in oral cavity. It is infection of the tissues of the floor of the mouth. It usually occurs in adults with concomitant dental infection. Many dental infections, poor hygiene, patients don't bother about the carious teeth, and that sometimes can result into a serious infection of the floor of the mouth. It begins mostly in the submaxillary spaces, secondarily involving the sublingual and submental spaces. Not true Ludwig's angina till all the submandibular spaces involved. So for a true Ludwig's angina, all submandibular spaces are involved, sublingual, submental, submaxillary, all spaces should be involved. Causes are mostly gunshot. If we talk about the causes, there will be gunshot wound in case of war. Our what we can call as officers, our army persons can have this type of injury, penetrating stab injury, or sometimes periapical or periodontal infections, mostly in case of second and third molar posterior part of the jaw. We can say molar teeth commonly show the infection. And clinically, if we see, there will be swelling in the floor of the mouth causing elevation of the tongue, firm and painful condition, diffuse swelling in the floor of the mouth, difficulty in eating, swallowing, breathing, chewing, fever and respiratory distress, swelling involving the neck. It may spread to the parapharyngeal spaces. That's why it can compromise the airway of the affected person, which can lead towards the severe conditions. So the treatment is, first we go towards the antibiotics to minimize, to remove the infection, and then side by side we have to do tracheostomy to maintain the airway of the affected person. Then there can be cavernous sinus thrombosis. It's usually a late complication of an infection of the central face or paranasal sinuses. Same that cellulitis sometimes can spread towards upper portion, central face or paranasal sinuses. There can be bacteremia, there can be trauma, infections of the ear or maxillary teeth are the most common causes. Then important disease with high rates of morbidity, again very severe condition, very serious condition. And cavernous sinus is at the base of the skull, so that's why it is a very serious condition. If we talk about the bacteria, Staph aureus accounts for approximately 70% of all infections, and then Streptococcus pneumonia, gram-negative bacilli, anaerobes can also be a part of such infections. It can affect both male and females, all ages can be affected, with majority mean age around a young 22 years of age. Clinically, if we talk about, if we see in the picture, it can affect the vital organs, no specific early signs and symptoms. Patient initially complaints of simple sinusitis and or mid-face infection. There can be headache features. As the infection spreads posteriorly, patient complains of orbital pain, fullness of the affected area, swelling of the affected area, accompanied by periorbital edema, visual disturbances. Without effective therapy, signs appear in the contralateral eye by spreading through the communicating veins to the other part of the coronal sinus. Eye swelling begins as a unilateral process and it can spread to the other eye very quickly within 1 to 2 days. And there is pathognomic for cavernous sinus thrombosis. It, patient becomes confused, drowsiness, coma conditions can happen. Periorbital edema, increased bulbar pressure, systemic signs indicative of sepsis. So the treatment is antibiotic therapy, anticoagulants, corticosteroids, and sometimes we have to go for surgery to save the life of the patient. Now, the spread of infection in the tissue spaces around the face. Infection of the teeth arises from pulpitis, associated necrotic dental pulp that initially begins on the tooth surface as dental caries. Then there can be localized or quickly spread through the various facial planes, facial spaces. Odontogenic infections, it may be primary or secondary to the periodontal, pericoronal, traumatic, or post-surgical infections. Typical infections originate from the caries. So main source is the caries, the affected tooth, and then infection can spread to the spaces, the areas of the face. In the pulp, infection develop as a tract through the root apex, burrow through the medullary cavity of the mandible or maxilla. Infection perforate the cortical plates, drains into the superficial tissue, means when it comes from the plates, the bone, it enters into the soft tissue, what we call as cellulitis, and superficial tissues of oral cavity, and then track into the deeper facial. So from the cellulitis, it enters into the deeper tissue, into through the musculars, and then other planes of the orofacial region. Patient with superficial infection may complain of localized pain, edema, sensitivity to temperature and air, and with deep infection, patient usually complains or abscess that spreads along the facial planes. It may complain of fever, difficulty in swallowing, breathing, and opening of the mouth, just like ludwig's angina, cellulitis, bigger swellings, trismus, like such type of features. The tissue spaces like buccal space, the parotid space, sublingual space, submandibular space, then submental space, lateral pharyngeal space into the neck, retropharyngeal means from the face it can spread towards the neck of the patient, towards the respiratory of the patient. These are in the picture we can see the facial spaces. The green one are the palatal spaces, the maxillary region, and the buccal spaces. The blue or purple things we can see. So infected dental spaces along with the source of infection. The buccal space, we can see maximum premolar, molar, mandibular molars, maxillary molars, premolars, and mandibular molars causing infraorbital, zygomatic, buccal infection. Whatever bones are present in that area. In some mental cases, mandibular anteriors causing infection in the submental space. In submandibular space, mandibular posterior teeth, premolars or molar causing swelling in the mandibular area, lateral cervical region, spread of infection into the parapharyngeal spaces, below the ear, into the neck area, then canine space, infected maxillary canines causing swelling in the maxillary buccal vestibule. Pathogens, they travel in the facial planes from one space near the infected site to another distant space by the help of inflammatory exudates, spaces when infected, they can undergo cellulitis, ludwig's angina, osteoma. So basically that similar events happen, and infection takes the form of a severe infection in the affected person. This is the interrelationship of that periapical infection. Pulpitis, which can be either acute or chronic, it converts into apical peritonitis, abscess or granuloma again. Then it can cause osteomyelitis, then periosteitis, then it can either cause pulpitis or abscess.